Let me introduce our speaker, Jeffrey Hbner. He's a clinical instructor and a volunteer preceptor, family medicine at the University of Washington. He's family physician, community health centers of King County in the Renton Clinic, serves on the board of the Washington Academy of Family Physicians, and is an active founding member of the National Physicians Alliance. Medical degree from the Medical College of Wisconsin, Milwaukee, one of the healthy areas on the map, if I remember correct, and residency in family medicine in the Harborview Underserved Tract at the UW. His clinical interests include end-of-life and palliative care, sports medicine, prevention, genetics, cross-cultural, and complementary medicine. The appointments and awards include the American Medical Student Association Radcliffe Fellow to direct work on universal healthcare initiatives in research, advocacy, and education, Washington Health Policy Program Fellowship with the Federal Agency for Healthcare Research and Quality, researching health disparities and international initiatives, American Academy of Family Physicians, Bristol-Myers Squibb Graduate Medical Education Award, and the Medical College of Wisconsin, Boulder Ethics and Walter Z Leadership Awards. So with all those awards, Jeff, we are expecting a great and timely talk. We know that you are going to be the only one who is going to stay on time for us.
Indeed.
And I will open, is this it for you?
Very good.
Perfect. Okay.
Thank you.
Thank you very much.
Thank you very much, everyone. I just heard an interesting perspective at a talk recently. The U.S. healthcare system is actually the 6th largest economy in the world. Just think about that. Okay, so for that money, we have lots of services. We have plenty of physicians. Actually, this is in hot debate in health policy circles, whether we have enough. We certainly have a shortage of nurses. We have outstanding research right here at this institution. We have innovative and plentiful technology in this country. But unfortunately, as you've heard, the results are not good, and that's what we need to pay attention to. You'll hear in the presidential campaign this year, we have the best healthcare system in the world. But do we have the best results? You've heard that we do not. They include variations in quality, reduced access to services. There are 47 million Americans that do not know next week how they will get health care if they need it, and poorer health outcomes than we should for the money that we spend. One little sidetrack, this is a project I'm working on right now, is why we spend so much money in this healthcare system, and actually pharmaceuticals have part of that role. Pharmaceuticals, I prescribe them every day. They're innovative therapies. They save people's lives. They extend people's lives. I obviously spent a lot of time studying them, so don't take this the wrong way. But maybe we're misdirecting some of the money that we spend on them. The industry itself spends $7 billion a year marketing to people like myself, despite me spending 4 years of medical school, then 3 years of residency, if you do specialty training, even more. And unfortunately, the research shows that their high-tech marketing, Wall Street, works, and it does affect our prescribing habits. Many physicians actually do not believe this, and actually, it's a bit of hearsay to say this in some circles, but people are starting to realize this. There are 90,000 sales reps, actually, and that's 1 for every 5 docs, which is actually more than almost as many as they have lobbyists in the state capitol here and in Washington, D.C. But this creates lots of conflicts of interest between the medical profession and the pharmaceutical and industry. And it leads to reduced levels of evidence-based prescribing and sometimes poor quality care. Just think of Vioxx. You hear about one of these drugs, unfortunately, once or twice a year, that actually was overprescribed and led to poor health outcomes, sometimes excessive death. There's actually a bill in the state legislature right now that would help get to this problem. Physicians' prescribing profiles are actually data mined without our consent. So what happens is the drug companies can find out exactly what I prescribe to each person. They get rid of the patient identifier information, but they are able to find mine, and then they can send a sales rep into my office or they can figure out how to do their ads for our medical journals and try to redirect our prescribing. It's not good, and actually this bill would help outlaw that practice. So anyway, getting back on track, what I want to emphasize is that health insurance coverage does make a difference. The Institute of Medicine from 2001 through 2004 did some sentinel work on this, compiled all the data, and found conclusively that people without health insurance are more likely to live sicker and they're more likely to die younger. They're less likely to have a regular doctor. They're less likely to be able to afford their medications. They're less likely to get the cancer screenings they need, and they're less likely to get necessary treatments. I just had a patient last week that exemplified this perfectly. He's about 55 years old, had not had routine health care, had been dealing with chest pain for several months, showed up in a local emergency room, was told that he had coronary artery disease, proceeded to have 2 cardiac stents placed to open up his coronary arteries, had 1 follow-up visit after the hospitalization, but has no health insurance, got a $50,000 bill, does not know what to do with that bill, and then was afraid to go to the doctor and follow up. He's been off of his meds for his cholesterol and his diabetes for the last year. What's going to happen? This I see in my clinic every day. So people had been doing a lot of graphs and research, and finally they figured out, were able to develop some methodologies that showed that actually annually it's estimated 18,000 people die in this country because of their lack of health insurance. Okay, so we're going to go to something happier. Actually, this is a cute little tyke. This is a photo of her on her first birthday. And I just want to provide a few stories quickly to sort of exemplify things a little bit more. But we're all facing the problems that our healthcare non-system provides. And increasingly, that's why this issue is coming up in the presidential election, because it's hitting the middle class. This is actually my daughter. And I happen to find out that she's on my wife's insurance plan. It turns out my wife decided that maybe we shouldn't go to the 9-month well child visit. Normally, she always wants to take our daughter to the doctor. I'm not the real doctor for her. But she said, we just got a bill for the 6-month-old well child visit. Now, how many people know how many times you take an infant to the doctor? If they're healthy, you're supposed to go at 2 weeks, 2 months, 4 months, 6 months, 9 months, 1 year. Her annual preventive medicine benefit was only $300, so the 6-month well child visit was not covered, including immunizations. So my wife says, why do we need to go to the 9-month? Okay, you can examine her. Well, luckily, there's no immunizations at 9 months. But then at 1 year, still on this annual year for the plan, you have 4 required immunizations and 2 more that are recommended. Well, luckily for us, it's not that big a deal. We can afford the cost. But think about other people that are working hourly wage jobs that are just managing to put food on the table or pay their rent, dealing with a foreclosure. Maybe they're going to skip those immunizations in that developmental assessment. I just want to mention briefly the role of health centers in our non-system of healthcare. Community health centers actually are federally designated. They're in urban and rural areas. Their doors are actually open to everyone, but their mission is to take care of people without insurance or Medicaid. They serve about 20% of the low-income uninsured in this country. 70% of our patients live in poverty. But the care we provide there is excellent. It's comprehensive. It includes medical, dental, and behavioral health. And community health centers save up to $17 billion annually via reduced ER costs and hospitalizations. But make no mistake, this is a Band-Aid for our non-system. In the past 5 years, health centers are suffering from the weight of a 45% increase in the number of patients that walk through our doors without health insurance. I just want to do one more story. I'm not sure actually if in your previous sessions or future sessions you're going to learn how to do a history and physical, but when you go through medical school, this is one of the things you spend years learning how to do as you talk about cases with your colleagues and your teachers. But I want to tell you about one patient. Her name is Jan. I actually changed her name. And her chief complaint was shortness of breath. She's a 55-year-old white female, with 3 months of insidious but progressively worsening shortness of breath. And it was so bad that actually her children were having to carry her up the stairs to her second-floor apartment when she would get home from work. She was still going to work. But she had no health insurance, and she was afraid to go into the doctors. Finally, it got so bad, one of her kids made her come in, and I saw her. This was one of the rare times as a family doctor you got to actually be a hero. But social history, she has 2 children, she's a non-smoker, she works an hourly wage job. On exam, she looked normal, at rest. She was afebrile, there were no signs of infection. Her lungs were clear. Her heart exam showed a very slow heart rate, so I proceeded to get an electrocardiogram. And this is similar to what I saw, which was 3rd-degree heart block, which some of you may know is life-threatening. So she was immediately sent to the local emergency room. She proceeded to get a pacemaker the next day, and I'm happy to say she's had a good ending so far, happy ending so far. But she still doesn't have health insurance. She's not getting the follow-up she needs, and I worry about her a lot. She doesn't come in as often as I'd like to see her. Her blood pressure isn't as well controlled as I'd like it to be because she's still dealing with all the other issues mentioned previously. I'm not going to go through all these, but suffice it to say, this is sometimes an average day at our health center, maybe an average week, but many, many people not getting the care they need to function. So, getting to some solutions. One thing you're not going to hear about in the presidential campaign is the role for primary care. And I want to impress upon you that as you listen to the candidates debate, you're going to hear all kinds of terms thrown around, but we need to start thinking about what makes the foundation of health in this country, and in the provision of health care, what will be important. Many, many studies show, and I don't have the graphs for them, but many, many studies have looked at this. International countries that have strong primary care-based systems, along with universal access, are well documented to have higher scores of patient satisfaction, improved preventive services and early cancer diagnoses, decreased emergency room visits and hospitalizations, improved quality and outcomes for diseases of heart, lung, and others, and decreased death rates or higher life expectancy. And all of this actually costs less in those systems. Unfortunately, our system is not well poised for this right now, because to have a strong primary care foundation in your system, you're going to need primary care physicians and other providers. Right now, in the US, it's about 35% of our health workforce. In other countries, it's 50%. And the number of medical students that are entering family medicine and the other general medicine specialties has decreased by about 50% over the last 10 years. That's a whole other talk in and of itself, but that's something we need to think about. If you were to go to medical school here, as you go, and this is the #1 primary care institution in the country, but there is a hidden curriculum, and you've heard about it in some of the ways already, but as you go through your training, primary care is not necessarily valued like it should be. You hear different things from your peers. I was told many times, you're too smart to go into family medicine. So we need to start changing those things. Here at this institution, there actually has been a movement, both amongst the students and the deans, I'm very happy to report, to work on this problem. And it goes all the way into the types of students we actually admit into medical school. And I think you're going to see improvement in the future. About 10 years ago at the University of Washington, approximately 30% of students went into family medicine, and more recently it's only been about 10%. I do have a couple of graphs. We actually do have some comparisons in this country, too, amongst Medicare beneficiaries. When there is a high proportion of general practitioners in the population, the spending per beneficiary goes down. And I'm happy to report that Washington's in the lower edge of that. Similarly, with a higher prevalence of general practitioners, quality of care goes up. And again, Washington's at the leading edge of that. But to enforce that, we need to continue some of the changes I've been talking about. So instead of talking about individual mandates or employer mandates or single payer or national health insurance, many of the medical societies right now are talking about the need to have a medical home for all. Everyone should have a family doctor, or general practitioner. In fact, Very rarely, which happens in organized medicine, 4 major medical societies all came up with an agreed upon definition of a medical home for all. Doesn't that sound nice? You each would have a personal physician who has whole person orientation, who realizes what's happening in your family or your community. Care is integrated amongst education, teachers, potentially, counselors, behavioral health, so you can work on some of those behavioral issues. The other components that make up a medical home, actually group health is very innovative right here in this community on many other practices. We're trying to work on these at our health center as well. But you have a team-based approach, coordinated services using electronic health records and email, regular preventive service reminders, group visits, and continuing quality improvement efforts. This is just a graph showing the decline in med students' interest that I mentioned earlier. In 1997, 2,300 US medical students went into family medicine, and that declined all the way down to 1,100 last year. Part of that gap's being made up by international medical graduates from other countries. So another way to look at all the proposals you're going to hear about this year and next year with the elections are to use some principles that the Institute of Medicine came up with to decide on how to evaluate healthcare reform proposals. They decided that coverage should be universal, it should be continuous, which means that if you lose your job, you still carry insurance with you, pre-existing conditions are not accounted for, etc. It should be affordable for individuals, families, and society, and should promote equity. This is sort of some of the alphabet soup of the different sorts of proposals you're going to hear about right now. For example, Senator Obama and Clinton are talking a lot about whether you should have an individual mandate or not. Unfortunately, nobody's talking about national health insurance as an option, even on the table. But that would be something where everybody is in right away, just like Medicare. Now, people get hung up on some of the terminology as well. And in other countries, they don't necessarily all have a single payer system as you might hear, but they have a guaranteed public access for everyone. And what does medicine have to say on this? Unfortunately, the history is not very good. When organized medicine gets involved, it tends to get ugly. This was the start of Ronald Reagan's political career, actually, in 1965, when Medicare was being debated in this country. He was recruited to work against it. And the American Medical Association was hand in hand. There actually was something called Operation Coffee Cup, and a record was sent out for people to play in their houses and with their groups, book clubs all over the country. And his concluding line was that, must have been very terrifying. One of these days, you and I are going to spend our sunset years telling our children and our children's children what it once was like in America when men were free. This was how Medicare was described. But I'm happy to report, as I mentioned, that medicine, especially medical students and the new generation, is certainly getting more involved with political activism, as we were called to do in the first presentation. In fact, historically, not many medical societies have supported national health insurance. The students always have, in a group called Physicians for a National Health Program. Recently, the American College of Physicians, which is the organization for general internists and medical subspecialists, has agreed that single payer would be an option. It likely will not happen in the near future in this country, so we need to build upon a public and private partnership to achieve universal coverage in the meantime. The AMA currently is asking for proposals that would provide tax credits, health savings accounts, and some safety net expansions. But they're very different views of how to achieve health coverage. And I'll just say, too, if you were to talk with medical students here in the school, you might find something similar, as was mentioned earlier. This was actually a study I did before I came to residency, and it was a nationwide random sample survey of medical students. 70% of first-year students supported universal health care. And at the end of medical school, only 61%, which was a significant decline. Interestingly, students were more likely to believe that practicing physicians did not support it. So there's something happening. There's an expectation that as you move through your medical training, you're not going to be for this anymore. But students overwhelmingly agreed that the public supported it. It'll be interesting to see what happens from the beginning to end of your mini medical school. So just to briefly review, the presidential campaign is fast upon us. There's two basic approaches being debated amongst the candidates that are left. On one side, you hear about tax credits to buy individual insurance policies, health savings accounts, high deductible coverage, turning the market over to you, increasing choice. But this is sometimes you need to go deeper, because actually that type of a system that is being talked about would be perhaps a more radical departure, you might say, from what we currently have, where most people get their insurance through their employer or through a public program, as opposed to everybody being turned in on their own to find their own policy. And then on the other side, you're hearing about public-private partnerships and whether to have this mandate for universal coverage, as they do in Massachusetts. So it's interesting to see how things will play out there. I just want to mention at the bottom, I'm actually really active on some of these issues, and it's frustrating because, and I'm sure we'd have opinions and discussions as wide as the room is here about this right now, tonight, if we had the time. And yet we still all agree on the foundations that were talked about. So right now, I think it's more important, actually, that we develop that groundswell and demand for change instead of getting caught up in various policy proposals. The unfortunate thing of what happened in the early 90s, if you look back at the history of that, was that Bill Clinton was elected on a mandate to provide universal coverage, and then we ended up with nothing, and then 20 years later, we're still in the same boat. So if that public will and demand and political will is there, something hopefully will progress and happen this time. But this isn't actually a clip. This is the old Harry and Louise from the early 90s, Beware. There's going to be talk about socialized medicine and these other buzz phrases, and I urge all of us to, let's get to the bottom of this and actually have a meaningful debate about what's important for health and healthcare in our society. To that end, in the Washington State Legislature right now, there's a bill 2536, which would actually create a citizens work group, have town meetings around the state to get into these issues, and hire an actuarial study of 5 different types of proposals to see where they come out. These are the types of discussions we need to have more of. So I'm going to wrap up there. Thank you.
Thank you. So we are open for questions. The lady there, right there, we have a question.
My question is, bad health care and therefore bad health, are they just spawn from bad education and culture and the growing divide between upper and lower class? So if we solve the bad education problem and the culture problem and the growing divide problem, would healthcare and therefore health just resolve itself?
I think the upstream problem is the gap between the rich and the poor. It's relative poverty. It impacts race, but race has an additive effect that's separate. What we need to do is to compress the gap between the rich and the poor, as both Presidents Roosevelt and Nixon wanted to do, and then the other things will sort of happen automatically. That's my opinion.
I would just add, there's a reason why my constitutional amendment, I got no clapping on the constitutional amendment, too. Is that education and health are really intertwined and interrelated, and you really have to address both to solve either problem. There's an adage that says for kids that you can't educate an unhealthy child, and you can't keep an uneducated child healthy.
So following up on that particular question, and you mentioned the issue that race is an independent risk factor, right? In this, do you all agree on that? Is there more than the study that you showed? You showed one study that clearly had shown that the white lady had the chance in the poorer scale to be. Now, I'm serious. Can you really dissect out poverty and education from race?
From the race, that was what the Institute of Medicine did in 1999. As I mentioned, they looked at 600 different studies and found hundreds of them that controlled for issues of socioeconomics and many other factors, insurance status, that would have explained why health outcomes were different, and they still found that there was a racial difference in those health outcomes. So that's
and how do you solve that problem? Or how have other countries dealt with it? All right.
Is there
I'm coming back to you guys.
in which the Africans or blacks have the same health outcomes as whites? Yes, Cuba. Health outcomes are the same for Afro-Cubans and for whites. And they didn't used to be, but the policies that Cuba has undergone have resulted in that outcome. So same sort of thing. Focus on equality.
When you take out the factors that contribute to different types of care, the factors that we would never want to admit that we infuse into our healthcare system by having evidence-based practices, guidelines that help support the best practices, the best reinforcement of good practices, and monitoring, people actually measuring what's happening, then you start to reduce those gaps.
All right. Number 2.
Yeah, I have a question which is maybe partly just hopefully a very brief statement which is related to some of these issues. And I like to say that I'm strongly in favor of a national health care program, and I'm strongly in favor of reducing inequality in the United States. But I think myself that our understanding of how socially to eliminate inequalities in health is nowhere near as advanced as has been implied by some folks tonight. And we certainly, I mean, in terms of medical care treatment, we know that if you give people an antibiotic, the right antibiotic, it's going to eliminate their infection. But the social issues are much more complicated. So let me just give you an extremely brief example and ask for your reaction to that. So one of the interesting charts you showed was variations in health across states in the United States. And it is true that the states with the least economic inequality have the highest life expectancy. Those states, such as the Dakotas, Minnesota, Iowa, are also characterized by a number of other interesting features, which include a very strong tradition of stable family structures, high levels of education. People go to graduate from high school and go to college. They're homogeneous, basically homogeneous ethnically and racially. Now, I raise that, and this is really my question. How are you going to separate out the effects of economic inequality as opposed to these other factors? So if I'm a policy person and I want to figure out how to equalize health in states in the United States, which am I going to pick to focus on? Well, one solution is economics, but there are also other possibilities, and I just like your reaction to my statement and what your suggestion would be for taking all these various factors and then using them to eliminate health disparities in the United States. So, for instance, working on education is a different issue than simply equalizing incomes. So I'd be interested in people's
That is the question. The question is actually, can you react to his statement in any way? Do you want to start this time, Ben?
Basically, in epidemiological studies and multi-level studies and hierarchical modeling, you can control for all of these factors. And there are some criticisms of some of the studies in that people don't account for race properly, for example. That's one of the things that you're getting at. However, race is a social construct. It has no biological meaning. There is a variety, basically, the United States has the most average number of years of education per person in this, of all countries in the world. That is, we are the most educated, and yet we have the worst health. And so I think, again, it is the basic political structure, the hood-robin-osis. Osis at the end of a word means more of, and hood-robin is taking from the poor and giving to the rich, and we have much, much more of that than we ever had before. And that's the basic thing we have to do. Societies they always reverse rising inequalities in some form or other. And it's going to happen here. It's just how soon and how it comes about. But Business Week was right. You see, we have been sold on thinking that hood-robinosis is good for us. It's our leading killer.
And I would just say quickly, this person, Michael Bird, who's in charge of the American Indian portion of National Health Foundation. He said something once where if you're at a meeting and everyone thinks like you, talks like you, has the same opinion as you, you're probably in the wrong meeting. So I really appreciate having people who have different opinions all coming together and talking about issues. The second thing I would say is that sometimes you end up having this argument about how to make the perfect system. And I think part of the issue that we're talking about is our system is so extremely bad that any one of those changes would make a significant improvement. So if you really addressed the poverty gap, you would make a big difference. If you really addressed the education issue, which has relationships to both the poverty gap and the health gap, then you'd make a big difference. If you really stated clearly that everybody deserves quality health care, then the solutions start to fall into place as far as I'm concerned. And it doesn't get as complicated as everyone likes to think. You could still save money.
The lady over here, let's make the questions relatively short. We have 10 minutes left. We have 6 questions at least. So short question, short answer.
Okay, hopefully this is a short question. The one thing that wasn't talked about was how we pay for this, and that the taxes, the increase in taxes, and what other countries pay in taxes. And my question is, in an age where we see more and more greed, and more people with very selfish, I don't want to pay any more taxes, to the point of a lot of narcissism and terrific consumption, how do we convince people that, we're going to have to raise taxes to accomplish this goal, and to give health care to the people that really, all of us?
So the assumption is, all right, the assumption is we need to raise taxes to pay for this. This is going to cost more. That is the assumption that she is talking about. So your answer, Jeff.
Which is partially a false assumption, because you may not necessarily have to increase so much as people think or as is portrayed. If you add up the amount of out-of-pocket expenses you're paying, your co-payments, your deductibles, your premiums, along with the tax increase, it will actually be less than what you pay now for all those expenses. So there's something that's not talked about frequently in the political debate. But getting more to the qualitative aspect of that, which is if you go to some interesting websites, one is herndonalliance.org. There's actually a family doctor here who's another one of my mentors at Harborview, Bob Crittenden, who's doing a lot of groundbreaking research on how to apply the concepts politically of how do we care for one another and think about the community in reforming our healthcare system.
So we need PSAs to educate people about what you just said.
Yeah, and we need to have dialogue and conversation and actually interact with one another.
Just quickly, 12 years ago, Taiwan instituted a nationalized healthcare program, and they started looking at their mortality rates and their costs. 12 years ago, they were spending 5% of their GDP on healthcare. After instituting a nationalized health program, they now spend 5% of their GDP on healthcare. Their mortality rates are starting to improve incrementally as well.
So what I guess you're hearing is we don't need to spend more of the GDP. We need to do it more wisely. And perhaps that is one solution. Next question.
That's wonderful, because that dovetails into what my statement is going to be. I would suggest that the insurance, hospital, and pharmacy industries operate on more of a service rather than a profit basis. Recently, there was a study in the Business Journal that a local well-known hospital, unnamed, had patients who came in who were triaged for just general pain, discomfort, and so forth. They were assigned to a 6-week course of physical therapy. At the end of 6 weeks, they were discharged into home care, end of their treatment plan. At the end of that same period of time, the organization looked at their profits, and their imaging and labs were down. And they said, oh, we can't be doing this because we're losing money. So oftentimes a simple solution, or I've heard no one here mention complementary or alternative methods, of which I'm employed in, cost so much less are so much more effective and actually touch people. So what's your reaction to that
Complementary
suggestion?
medicine. You are the specialist in complementary medicine.
Well, no specialist. Interesting. That was
All right, well,
the
you know.
long bio, yeah. I knew I'd get burned for that.
I've been talking about specialists every time I have been here talking.
Yeah.
So I just get that into
Actually,
my
at
mind.
our community
Sorry.
health center, Community Health Centers of King County is a pretty innovative model on that. We have complementary medicine specialists in our clinics, and that's very unusual, especially for our patient population, because most of them cannot afford those services. But we have an acupuncturist on site, and a dietitian on site, behavioral health counselor on site. So those are important services to consider. And they all go together, but they also all need to be studied rigorously so we decide where to spend our money effectively.
I'd just like to point out that in 2005, the profits of the healthcare insurance companies in this country exceeded $100 billion. So anytime you want to mess with an industry whose profits are that high, we need to all band together. Maybe we need to do the constitutional amendment. There should be no profit in healthcare. Absolutely.
All right. 1-on-1. Now the next lady over here.
Yes, my question, a few months ago I was involved in a serious car accident. I landed in the ER. A few days later, I went to follow up my primary care doctor, and I was informed that he would not see me because he did not treat people with auto accidents. So, and I should say that this is a doctor who was previously employed in a very reputable Seattle medical group and has since gone out on his own probably about 8 years ago, which I thought was a great thing at the time. I haven't actually seen him since, but I thought you guys might want to talk a little bit about that particular situation, and also, in addition, the exclusion of Medicare, Medicaid, auto accident, Department of Labor, all of those things that I think it's getting harder and harder for certain patients to get care because doctors aren't getting reimbursed as much. I'm making assumptions here, but doctors aren't getting reimbursed as much. The insurance issues are too delicate. There's too much work to be done.
Yeah, I think that gets into the silos that Dr. Danielson mentioned, and the fact that our non-system is completely fragmented. We're all churning away in different silos, trying to do what we can to stay afloat and make money. I mean, even those of us that work in a not-for-profit, mission-based system, there's a certain number of patients I need to see every day. I would hazard a guess that that doctor would have been happy to see you, but someone at the front desk or an admin put up some rule saying they can't see you for some reason.
He's on his own, so he's the only doctor there. So
That's
I think
what
that
it's
was
coming
his
to,
decision,
unfortunately,
yeah.
that some people, decide to make those decisions.
Yes.
You know, in Sweden, a surgeon and a teacher gets paid the same. I think it should be that way in this country.
All right. Should I participate in this discussion more effectively? No, I was actually going to ask this panel if you thought that any physician, for starters, can deny treatment to a Medicare patient and continue to exercise the profession. Is that morally right?
Do you remember what the last thing on my bio was? No, sorry. I absolutely not. I mean, it's appalling, and actually, but it's something that is being faced in this community. We're actually facing crises in many subspecialty areas, and I'm not going to pick out any in particular, but a lot of you who work in the setting as I do know what I'm talking about. There are patients who literally cannot get the services they need. You hear in the presidential campaign, you're going to hear about waiting lines in other countries, and we have endless lines in this country of patients who cannot get the services they need. I think it would be appalling to ever say, I mean, when you start medical school, none of us would ever have that ethic.
Correct. But some of the things are surprising. You know, I came from an underdeveloped country, and I came here, and I thought, and I still think that we have a great opportunity to make the system better, let's say. I can't believe that in Canada, you characterize health as being better. Health, not healthcare, but health being better than just south of the border. And yet, every Canadian that I know that is a physician working in Canada tells me, our system is horrible. The waiting lines are horrible. People are waiting and waiting and waiting, which makes me believe that maybe not providing contact to physicians may have its own value. I have been told, I used to smoke when I came here, and I've been told if you want to live longer, stop smoking. I look at your slide today, and I look at the Japanese people. They're all smoking. They're all living a lot longer than I'm going to live, and I'm nervous about that, so I don't know.
I just ask you, do you want health or health care?
I want health.
Okay, me too.
Health. All right, where are we? Are you the next person?
I think I'm the next. My question is, you mentioned the shortage of primary care docs. And to what extent do you feel that NPs and PAs can fill that, nurse practitioners and physician assistants can fill that gap?
That's a great question. I mean, there's a strong role for them, actually, and actually that's the model in the medical home that I think is being espoused there. There's probably a physician leader of the team, but those important players will definitely be seeing patients and helping provide that, and probably in some cases in a more cost-effective world.
Mm-hmm. Thank you.
It is interesting that if you look at other countries, I mean, our projections right now are that we're going to have a physician shortage, whereas our projections only 10, 15 years ago on manpower were that we had an excess of physicians. If you look at current situations in Europe, in certain countries, Ireland, England, there are too many physicians that don't have any work to do after they finish their training. So I'm just wondering, are we making it up, physicians, that we are going to be in short supply so as to increase our income? All the studies are coming from physicians. Or are we really going to be facing a shortage of physicians? What do you say? You're nodding.
We really have a shortage of physicians, and we have a shortage of physicians relative to the needs in our society. And it's the shortage in the lowest paying spectrum of the physician pool that we are short in. So it's not creating some false story. We really do have a shortage of primary care physicians. Doctors who are training today have to make very difficult decisions about how to pay off their student loans and how to make themselves financially stable after struggling through school for many years. That's an issue. But the bigger issue is that primary care is at the lowest end of the pay spectrum. It's plenty of money, but it's at the lower end of this pay spectrum for this profession, and that changes the way people make decisions. But we have a shortage, an absolute shortage, there's no doubt about that.
The lady here.
Okay. I think it's very clear that there's a very strong link between poverty and all these disparities and health. But I think it's fair to say that it's going to take a very long time to solve things like institutionalized racism and poverty and all these sorts of inequalities. So assuming that we had the political and social will today to make those changes happen, how long do you think it's going to take before our country has a respectable ranking in the, World Health Olympics?
Great question. So the question is clear. If we had the political will to solve the problem, you all indicated that the solution is relatively simple. It's a matter of courage, social courage, to say we want to do that. You proposed the amendment, or you said, universal coverage. How long would it take to do it?
Well, Japan went from, in 1945, being relatively unhealthy to 1978 being the healthiest country in the world, and that's about 33 years. And I said we gave Japan the medicine it needed to become the healthiest country in the world. The medicine had 3 ingredients. The first ingredient was demilitarization. Japan can never wage war. It has to resolve all disputes peacefully. It's written into the Constitution. The second D was democratization. Namely, everybody had the vote. The right of labor unions to organize and bargain collectively was written into the Constitution. There was a public health clause written into the Constitution. And the third D was decentralization. Japan was ruled by 13 big family corporations, or zaibatsu, and the world's greatest population health doctor, who went there disguised as an Army 5-star general, Douglas MacArthur, wrote in his memoirs, "You can't have such concentrations of wealth and power and have a democracy," so he broke them up. And he also carried out the most successful land reform program in history. So all we have to do is take the medicine we gave Japan, or ask them to give it to us.
Import another thing from Japan. Thank you. That's last question.
Okay. I just have one last question, and that's that you've talked a lot tonight about the disparity in terms of wealth and income in this country. But one thing that didn't get mentioned tonight was that in other countries, a lot of the ones at the top of that list, medical education and education in general is heavily subsidized by the government and in fact is free in some countries. And here, if one is considering going to medical school, that's 4 years where you're paying, several, 20,000, 40,000 a year for that education, and then the residency in itself is another, you're being paid, but you're working 80 hours a week, how to make that more appealing so that people in the U.S. actually have an incentive to go into that field, and how does that affect healthcare?
It's a great question because I was just at a talk last week and Representative Jim McDermott was talking about the election season and the proposals you're going to be hearing about, but one thing he's going to be pushing for is for free medical school tuition, because in any healthcare reform proposals that are discussed, because that would free medical students of their debt and to go into what their passions are and what their ethics say they should do. I'm actually a participant in the National Health Service Corps Scholar Loan Repayment Program, and that's helping pay back. I went to a state-funded medical school, and I had over $100,000 in debt when I came out, which definitely did weigh on my mind as I make my decisions.
And you just ruined my dinner tonight because my wife is realizing that I'm still paying off my loans and working in a primary care setting, is wondering if she made the right choice in her physician spouse.
Well, I am delighted that you all stayed until the very end. I think we appreciated your participation and your questions. I thank you all very much for coming. I think we owe these three gentlemen a round of applause. They did a great job. Thank you. Thank you very much. Thank you. Thank you.